All right, so this is going to be the next lecture in this unit. So there's just 2 lectures at this time for this unit, lymphatic, and now we're doing respiration. And it's sort of, we went over some of this stuff in lab, but we'll go ahead and continue on here with respiration. So respiratory system, obviously the big thing here is getting oxygen, acquiring oxygen from the atmosphere. Cells obviously need energy and oxygen for health and growth and maintenance and defense and division. And so there are mechanisms that obviously utilize this oxygen, like we saw back in the NP1 with, for instance, aerobic metabolism using oxygen for these tissues to create ATP, but also just for survival of the tissues, right? We saw with the nervous system and the heart and other tissues without oxygen, pretty much there's no functionality there. So obviously oxygen is an essential component, and so respiration is our way of acquiring oxygen from the atmosphere, but also through those processes of utilizing oxygen, CO2 or carbon dioxide is produced, and that's how we can release CO2 back into the atmosphere. So oxygen is obtained from the air by diffusion. Basically, oxygen can diffuse across these very thin, delicate membranes at the exchange surfaces of the lungs, which are known as the alveoli. And then once that oxygen is in the blood, obviously it binds to red blood cells and carries, distributed throughout the system, and also can bind CO2, as we talked about, and return that back to the lungs where it can be expelled. So that's just a really general overview. If you'll see here at the bottom, there is also a link. Hold on just a second here. There's a link for respiratory system overview. It's actually kind of a cool look, this video online that this links to. It's a pretty cool look at how the respiratory system works, just sort of an overview, and it's by this artist who does these drawings, which is kind of neat to see the progression of the system. And anyway, so it's just a nice thing. If you want, you need to go to the other actual PowerPoint presentation in Blackboard. Make sure it's in slide, presentation view, and you can click on the link and you can watch that if you want. It's just, again, it's sort of just an overview, different way of looking at it. Students have had a pretty positive feedback about it to me, so that's why I keep it there as another sort of alternative to view respiration. All right, so click on that if you're interested. All right, so what is this respiratory system doing for us? Well, obviously the big thing is oxygen, as we talked about, and so the respiratory system provides this gas exchange surface area, right, in the alveoli between the atmosphere and our blood. That's where the exchange has to occur, right, and so it has a specialized system deep in our lungs where this oxygen can arrive and actually diffuse through these thin membranes into the blood. And as I said before, the CO2 then passes the other direction, and we'll look a lot at pressure and how air flows and concentration gradients and things like that. But that's sort of the basic, one of the big functions, obviously, is this, gas exchange that occurs. It also has the ability to actually move that air, right, from the atmosphere deep through the respiratory system down to the exchange surfaces of the lungs, where this exchange occurs. So we'll look at the actual movement of the air and how, breathing and inspiration and expiration actually work, and how that's helped by muscles of our thorax, etc. So we'll look at that process. Another function is protection, right? Sort of as we talked about before, and we'll see with the digestive system, our mouth, our oral cavity, is an easy pathway, an easy way for pathogens and bacteria and other types of things to enter our system. And so we'll see when we look at the digestive system, we have a very acidic stomach and other sorts of defense mechanisms there to protect us. And same thing happens here in the respiratory system. We have, the C cells, the defense system that live actually down deep at the alveoli to protect this respiratory system from this outside environment. Another thing we'll look at is the production of sound, right? You guys looked at this in lab with vocal cords and vocal folds, and how air passing over these vocal folds produces vibrations, and those vibrations produce sounds, of course, when we speak. That is what happens. Okay? And it also participates in olfaction. We won't look at that too much, but it is part of the overall process. All right? All right, so we looked at this in lab, but again, the organization of the respiratory system is divided into an upper and lower respiratory system, with the larynx basically being the sort of dividing point. So if we look at this image, you can see upper respiratory system, and here lower respiratory system below the larynx. The larynx sort of being the our Adam's apple area, as you know, or that's where our vocal folds are and all those types of things. So you can see that division in that image. Respiratory tract consists of a conducting portion, which is basically our nasal cavity that goes all the way down to those terminal bronchioles, and then a respiratory portion, which has the respiratory bronchioles and then the alveoli. And as I said, the alveoli are basically air-filled sacs or pockets deep within the lungs where this gas exchange takes place. And if you recall, way back in AP1, one of the first slides you looked at under simple squamous epithelium was an example from the alveoli of the lungs. And you can see the simple squamous lining this area, and we'll talk about how that really thin lining is what allows for this oxygen, CO2, to diffuse across this membrane as we look at that diffusion a little bit later. Okay? So respiratory epithelium, as I said, for gases to exchange efficiently, must be very thin, right? Less than a micrometer. As you know, as I said, simple squamous epithelium is down there. As you know, it's very thin, and so you need to be very easy for this oxygen and CO2 and these gases to diffuse across this membrane. So it should make sense to you that you want a very thin epithelium lining this alveoli, right? Also in the respiratory epithelium, you need a lot of space, so the surface area must be very large. And so as we'll see, deep in the alveoli, there are many divisions, subdivisions, and branches, and that allows to increase the surface area to about 35 times what we have in the surface area of the body to allow for a vast amount of gas exchange occurring to get all that oxygen into our system. Okay? Now the respiratory mucosa, again, has an epithelial layer and it's attached to an areolar layer. You guys know that. That's what a mucous membrane is. And this lines the conducting portion of the respiratory system. Okay? And if you look, like, for instance, at the trachea, right? We talked about this in lab, but it kind of looks like shag carpeting. You guys know that pseudostratified ciliated columnar epithelium is what's found in portions of this pathway. Okay? And so here's a nice image. If you look, here is the connective tissue. Here's the pseudostratified ciliated columnar epithelium. You can see the mucus cells, right? Those are going to secrete mucus. They have a nice mucus layer on the surface, like a mucus membrane, like we talked about. But then you can also see clearly the cilia, right? Those are the extensions on from the cells. And there's actually have the ability to move mucus. We call it sort of the ciliary elevator, where can actually the finger-like projections actually move, and they're able to process and move mucus up to the pharynx and keep this area clean to allow for air to pass through, right? That's the most important thing, keeping that area, that airway open, right? And so here's just a close-up of that section. You can see the goblet or mucus cells here, and you can see the cilia coming off of here, and you can see the connective tissue or lamina propria that's attached to. And so this would be airway, right, coming in this way to allow for passage of air deep into our respiratory system. Okay? So as I said, pseudostratified ciliated columnar epithelium, lots of mucus cells found in the nasal cavity in the superior portion of the pharynx. Just beneath that, in the inferior portion of the pharynx, it actually changed to a stratified squamous epithelium, which is what you find often in the oral cavity. You need, as we'll look at this in digestion, you need sort of a tough, more resistant type of epithelium as food and other things are going to be passing through. So that's why you see stratified squamous epithelium in that pharynx location. But then after that, superior portion of the lower respiratory system, again, we're going to see pseudostratified ciliated columnar epithelium again. You might see a little bit of cuboidal epithelium as you pass deeper into the smaller bronchioles, but then finally as you work your way down to the alveoli, as I mentioned before, very delicate, simple squamous epithelium, right? As we'll see, there are different types of cells that we're going to find down there, not only the simple squamous cells, but we're going to see surfactant cells that produce a surfactant. It's a fluid that helps maintain the pouch-like structure of these alveoli. And so again, the simple squamous is going to line the exchange surfaces of this alveoli as I described previously. All right, so you need a defense mechanism, right? As we've described, you have this, easy pathway for pathogens and microorganisms and other things to just enter into our system, right through our oral cavity or our nose. And so you need some sort of respiratory defense system to protect against these things. And so there's a series of filtration mechanisms that help defend us to remove particles and pathogens that may work their way through our system. And so first thing, as we saw, were the mucus cells and the mucus glands, right? They're producing this mucus that sort of covers these exposed surfaces, forming that mucous membrane. So you have a fluid sort of bathing those surfaces. And it makes it easier to trap things that may move their way through the system and harder for things to pass through. And so we also talked about the cilia and how they have the ability to sweep debris that may get trapped in the mucus. And I talked about that mucus escalator as the cilia can actually move through that process. Filtration in the nasal cavity, right? So we have nose hairs and we also have conchae and other types of things. They're going to help protect and remove larger particles. But we'll also see there are macrophages deep in this system that can engulf smaller particles deep down in the lungs that may pass through these other components of the defense system without getting taken up, and that's sort of the last line of defense, and we'll talk about those as we continue on in our discussion. So the nasal mucosa, warms and humidifies the air. Breathing through the mouth actually bypasses this process of what the nasal mucosa can do in terms of humidifying the air that passes through. And so this is the sagittal section of the nasal and oral cavity, as you guys saw in lab, and you can see quite a few structures. The pharynx is sort of what we've talked about before, and this is where we'll begin, sort of in the oral cavity, and then working our way down to the nasopharynx, oropharynx, laryngopharynx, and all the way down to the trachea and beyond. That's sort of how this will go. So you guys saw this in lab. So we'll start with the upper respiratory tract, and that is the pharynx. As I said, you have these three components, nasal, oral, and laryngopharynx, that sort of basically extend from the internal nares all the way down to the larynx and where the esophagus is located. Okay? The larynx, from that, the larynx, of course, is the sort of tip or the beginning of airway entering the trachea. Okay? And so the larynx, as we talked about, has this cartilaginous structure that surrounds the glottis, which is the opening, and you have this epiglottis that can cover over that, obviously, to prevent things that we swallow from entering our airway, right? We want those to go down the esophagus, which is in the back, so we have the epiglottis that covers over that. And we talked about the different cartilages, the thyroid, the cricoid, and the epiglottis that sort of protect this larynx. The thyroid is a hyaline cartilage, forms the anterior and lateral walls, has this laryngeal prominence, which you know as the Adam's apple, which you can feel. That is hyaline cartilage. Ligaments also attached to the hyoid bone. That sort of makes up the top portion of the structure of the larynx. Okay, cricoid cartilage forms more of the posterior portion, articulates with the actiniate cartilages. And again, this is something that you're looking more at lab. I mean, the epiglottis is composed more of elastic cartilage, and again attaches to the thyroid cartilage and the hyoid bone in terms of its structure. And so just in terms of the function, right, the thyroid and cricoid cartilages protect and sort of support the glottis, but also protect that entrance to the trachea, as I was mentioning, And during swallowing, the epiglottis folds over the glottis, protecting that, preventing food, as I mentioned, or liquids from entering the respiratory tract. And so here are some nice images of those things that I was talking about. Here you can see the laryngeal prominence, or the Adam's apple. You can see the hyoid bone right here. There's the epiglottis, sort of, you're seeing as an anterior view, so the epiglottis is on the other side of that. And what you can see nicely, again, after the larynx, which is right here, right, you can see the trachea begin. You can see nicely the tracheal rings, right, U-shaped hyaline cartilage rings that keep that airway open. That's the purpose of having these tracheal rings, right? And so here's the posterior view, backside. You can see the epiglottis right here. And then we have these vocal ligaments and the different cartilages associated with that vocal ligaments to allow for sound production to occur. But again, this is a nice lab topic where you got to see these models in those structures. Here's a sagittal section. You can see the epiglottis here. And then here you can see the corniculate and the arytenoid cartilage attached to the vocal folds, and that's where sound production occurs. And then below that you can see the trachea begin. So those are nice images of these sort of different components of the larynx, right? And so again, the corniculate and arytenoid cartilages, as I showed you in the previous picture, essentially open and close the glottis, but also involved in production of sound, as vibration, as air passes through those, vibrating those vocal folds, vocal ligaments or vocal folds and vestibular ligaments, and that is going to produce sound. Okay? And so that's the process that we want to talk about, is sound production. All right? Those vestibular ligaments lie within these vestibular folds, which protect these vocal cords or vocal folds, as you would know them, and gives you sound production. Essentially, air passing through the glottis vibrates these vocal folds and produces sound waves. If you recall from ANP1 when we talked about the process of hearing, it's a physical process that produces sound waves with wavelength and frequency and things like that. A good example I always use when I'm talking about sound production is think of like a stringed instrument, right, or a guitar or a violin. You produce sound by vibrating those strings, right, and those strings can make different sounds depending on how much tension is on those strings, how thick or thin the strings are, and that's the same thing that happens in our vocal folds, right? You have vocal folds that are longer or shorter depending on age and sex, and we have a different pitch or sound that is produced depending on it. But the bottom line is air passing through and vibrating these vocal folds is what's going to produce these sound waves. Okay? Make sure you have a good understanding of sound production. Right? Pitch can depend on the diameter, length, tension of vocal folds. And again, think about a stringed instrument. Right? If you play guitar, right, all the guitar strings are different. The diameter of those strings are different, right? And then you can put different amount of tension to get those chords in different, those strings in different tunes, and the whole thing together is going to produce a sound. And it's going to vary depending on the length and the tension and the diameter of those strings. And the same thing happens at our vocal folds, right? Vocal folds are also again known as vocal cords. For instance, children have slender, shorter vocal cords that can produce a higher pitch, whereas adult males, for instance, have a thicker, longer vocal cords that's going to produce a lower pitch, right? And so that's going to vary, and that's where sound production is coming from, is the vibration of these vocal cords. Okay, and so here's a nice shot of the vocal folds or vocal cords here, right? And then you have the vestibular folds over here. And you can see this in our nice model in lab. Also, as you work through that, here's the glottis in the closed position. Right? And there's an actual photograph through the laryngoscopic view just above the larynx, and you can see that glottis open, and you can see the vocal folds in that position. All right? And here's the epiglottis. You can see that's open as well. We'll be covering that at that time. All right, so after the larynx, then we move down to the trachea. Trachea, as you guys know, is the windpipe, right? This thing needs to be open. It's lined with pseudostratified squamous, pseudostratified ciliated columnar epithelium, and provides a nice sort of shag carpeting-like protection to trap debris and other types of things and move those through. And helps protect that pathway. But the key with the trachea is the windpipe, right? Keeping that airway open, right? And so here you can see the end of the larynx, the beginning of trachea, and this continues down to where it basically divides, and we start seeing it turn into what are called bronchi or bronchi, which are the divisions, the branching that is going to occur after the trachea. So that basic section, windpipe, is what's called the trachea. And we looked at this in the lab, but this is a nice cross-sectional view of the lumen of both the trachea, which is here, and the lumen of the esophagus, which is over here. And we talked about, look at the difference in terms of the openings, right? The esophagus opening is more collapsed, as you can see, and materials like food that pass through the esophagus to work their way to the stomach go through with that area sort of smooth muscle, which you can see here, sort of surrounding it, contracting and pushing the materials through what's called peristalsis. In the trachea, right, you want that open, and so to keep that thing open, you have these nice tracheal cartilage, U-shaped tracheal cartilage to keep that lumen open. Okay, and so that's a nice image of the difference between the lumens in the esophagus versus the trachea. But if you think about the physiology and what's needed at those sites, it sort of makes sense that the esophagus is more of a collapsed opening, whereas the lumen of the trachea is maintained open, right, for airflow. All right, so that trachea then divides into many branches and ultimately enters into what's called lungs. You guys know what the lungs are, left and right lungs that are in pleural cavities, right? There are different lobes of the lung which are separated by deep fissures. The lungs are not identical. The right lung has 3 lobes. It's a little bit larger, a little bit wider, but also is displaced upward to the liver, where the liver can sit right in beneath that. The left lung only has 2 lobes, right? A little bit longer, and it has what's called a cardiac notch. So it's just displaced just slightly to the left to allow the heart to fit in that location. Okay? So they're not exactly the same. At first glance, they kind of look just like a left and right lung, but there actually are differences. Okay? So here you can see an actual shot, anterior view of the lungs. Here are the illustrations of the lungs. Again, on the right, you can see superior, inferior, and middle lobe, right? And you can see slight upward displacement because the liver would basically go right here, okay? And then the cardiac notch, here you have, for the left lung, right, you have superior and inferior lobes. Only 2 lobes on the left lung, whereas we see 3 lobes on the right lung. And again, here is a cardiac notch to allow for the heart to basically sit right in that location, as you guys know, right? Probably a little bit so you know what that means. All right, so that is that's the lungs. On the medial surface, again, you have the pilium, which is this location, allows for the passage of vessels and nerves and lymphatics, and the primary bronchi are all going to move through those locations. So you see those on the medial surfaces of the lungs. And so here's a cross-section through, looking at the lung and the heart and its location. You can see the left lung, and you can see that cardiac notch, right? Here is the heart, and of course the opening to allow blood flow to pass through those locations. All right, so as the trachea divides and enters the lung, the trachea turns into bronchi, right, or bronchi, and produces what's called a bronchial tree, essentially, because you just keep getting these bronchi. They keep branching and branching and branching, smaller and smaller and smaller, until they finally reach the alveoli, where the exchange surface of the lungs are. So you have extrapulmonary bronchi and intrapulmonary bronchi. Extrapulmonary are the branching that occurs outside of the lungs. Intrapulmonary bronchi are the branching that occurs inside the lungs. Okay? And so here's a great image where you can see what's happening. Here's the tail end of the trachea. You have this division, what's known as the carina, where it divides into the left and right primary bronchus, or bronchi, and you can see the branching that occurs here. There still is a lot of cartilage in this primary, secondary, tertiary bronchi, but as you move closer and deeper into the lungs, right, you see the less and less, as you get to the smaller bronchi, less and less cartilage, and you're going to see in the bronchioles, the terminal, and the respiratory bronchiole, you're going to see very little, if any, hyaline cartilage, and now you're going to see smooth muscle that can help regulate the the diameter. And then as it branches down to what's called a terminal bronchiole, then a respiratory bronchiole, and then finally the alveoli, these little balls or sacs where gas exchange actually occurs. And the reason there are these balls or sacs with each individual alveoli, or alveolus, is for increasing that surface area, as I mentioned. So the more branching that occurs, the greater you're increasing the surface area to allow for lots of gas to be exchanged into the vascular system. All right. So this bronchial region, as you know, you guys have probably heard of bronchitis, which is inflammation of these bronchial walls. That is going to result in constriction. Of course, if you have constriction, it's going to be more difficult to breathe. So that's what bronchitis is that can happen. All right, so these bronchioles, tertiary bronchioles branch into these terminal bronchioles. Terminal bronchioles then, as I said, are going to have no cartilage, dominated more by smooth muscle. And that's why, like for instance, people who have asthma or have asthma attacks, for instance, or even if they're having a cold, that smooth muscle spasms deep in those bronchioles and constricts those openings, right? And so they take like an inhaler or something like that that can help relax that smooth muscle, open those pathways more. Because there really is no cartilage. The smooth muscle is going to dominate those locations. And so this is the very end of that pathway. So if we go back to this slide, basically this is what we're looking at on this next slide, which you can see right here. Okay? So you have this respiratory bronchiole, and then terminal bronchiole branching, and then finally you have this these alveoli, which are down here, right? And so these are the alveoli where gas exchange occurs. Again, they're sort of like alveolar sacs, essentially, which have many alveoli in that location. All right. So, as I said, essentially, smooth muscle is regulated by the autonomic nervous system. You get autonomic control that regulates the smooth muscle and therefore controls the diameter of these bronchioles. If you control the diameter, then obviously you're going to control airflow and resistance in the lungs, right? And so just like we saw with blood vessels where you can have vasodilation and vasoconstriction, you can get the same thing occurring at these bronchioles. You get bronchodilation or bronchoconstriction depending on the scenario and depending on what is happening at a given time, right? So bronchodilation is driven more by sympathetic autonomic activation, and that dilates those airways. And it should make sense to you that sympathetic, right, that's your fight or flight. If you're having a fight or flight, like for instance, exercise or some elevated level of activity, you probably want to dilate those airways, right, to reduce resistance, or you can increase flow because you're probably having an increased need for oxygen consumption and things like that during sympathetic stimulation. So bronchodilation occurs that. Bronchoconstriction, again, is sort of the reverse, right? This is more when parasympathetic is dominating, and so you get constriction of those airways. Also could be in the result of histamine release, as I was mentioning with allergic reactions can cause bronchoconstriction, as I talked about previously. And so asthma, again, is excessive stimulation and bronchoconstriction, which severely restricts airflow, making breathing very difficult when someone is having an asthma attack. All right, so we work our way down to these respiratory bronchioles, and those connect to those alveoli along what are called alveolar ducts. Alveolar ducts then end at what are called alveolar sacs, right? And this is where we have each individual alveolus that has an extensive network of capillaries and elastic fibers, and we'll see how this exchange occurs at these alveoli. And so here's a great image of the simple squamous epithelium found at that alveoli. And this should look pretty familiar, right, because we talked about this way back in ANP1. This is really one of the first slides that you looked at. And you can see the alveolar duct and the alveolar sacs. You can also see the makeup of arterioles. But here are the individual alveoli at the top. And that's, again, kind of what we looked at under the microscope way back in ANP1 where we were looking at simple squamous epithelium. Here's another really close individual image of each individual alveolar sac with the alveoli, and you see the ducts that lead into the sac. So you get the point here. There are many divisions that occur and ultimately lead into these alveoli, which have lots of sort of balls within each alveolar sac, again, to really increase surface area to allow lots of gas exchange to occur. Okay, so as we talked about before, the alveolar epithelium is a simple squamous epithelium. We talked about the reasons for that. The cells in this area are either type 1 or type 2 pneumocytes, which we'll talk about in a minute. Type 1 cells are basically the simple squamous epithelial cells. Type 2 cells are the cells that produce surfactant, so we'll talk about that process. There also are alveolar macrophages, as I mentioned, for defense, right? Because this is an easy way for debris and other types of pathogens to work their way down to this area. So you get defense and control by these alveolar macrophages down to this region. Okay? So, as I said, you have these two different types of cells. One is the simple squamous cells, which again just line the alveoli and allow for the ease of gas exchange. Another type of cell are these type 2 cells that produce surfactant. And surfactant is essentially an oily secretion that coats these alveolar surfaces. And the big thing, it reduces surface tension. It's a really important concept, because having a reduction in surface tension is going to allow for those alveolar balls or sacs to remain inflated, essentially, right? Preventing alveolar collapse, which would be very dangerous, obviously. Pneumocytes type 2, if they do not produce enough surfactant, you're going to have some serious issues with the collapsing of these alveoli and make very difficult respiration. So surfactant is a really important part of this overall physiology that's occurring and allowing for the gas exchange, right? If these balls aren't inflated, essentially, right, there's no way for the air to get down, right, and to get down to those components. So you need to keep those areas inflated, and the way to do that is to reduce the amount of tension across that surface, and that's what the surfactant does in that regard. And so here's a nice shot, close-up of an alveolar sac containing each individual alveolus or alveoli, several alveoli in those locations. Okay. Here is another really nice illustration where you can see all these different types of cells, right? You can see the simple squamous epithelial cells lining each alveoli or each alveolus. You can see so those are the type 1 cells. You can see the type 2 cells that produce surfactant right there. You can see the alveolar macrophages. You can see a capillary or a blood vessel. And look, if you look closely, and we'll talk about this in a minute, but look at the relationship between the simple squamous epithelium and the capillary, right? Really thin wall right there, right, to allow for gas to move and exchange across that membrane. And so we'll talk about that in a little bit. But this is a really nice shot of what's going on down deep into the alveoli. All right? All right, so as I was saying, the respiratory membrane, this is a really important component of the alveolus, and this is a very thin membrane across that alveoli where this gas exchange occurs. And there are essentially 3 layers to this respiratory membrane. As I said, the first part, of course, are the simple squamous epithelial cells, right? These are the cells that line the alveolus. And then, of course, beneath that, there is a basement membrane that fuses sort of the capillary to the simple squamous cell. And then finally, of course, there is a endothelial lining of the capillary. So you have sort of this 3-walled structure. And so here, for instance, is what it looks like, right? You have this. Here's the alveoli here. Here's the capillary up here, right? And so you have 3 compartments, 1, 2, and 3. Less than 0.5 micrometers is the size. So very thin, right? And so if you have oxygen here, right, for instance, you breathe in, the oxygen comes down to this alveolar space. It can cross over this membrane into the capillary where it can then bind to a red blood cell, right? Binding right there. And the red blood cell can carry the oxygen throughout the system, right? But the point here is that this is that membrane, the 3-part membrane called the respiratory membrane. Okay? So really important there. And so again, this thing dictates diffusion, right? It has to go across this membrane. It's very rapid because, as I described, it's very small, right? The distance is really short in terms of gas diffusing across that, right? And the reason for this, again, as we've talked about before, oxygen and CO2 are lipid soluble, right? So they can just diffuse across that membrane. And if you have, for instance, inflammation of those lobules where it's supposed to cross over, that is pneumonia. It can be very dangerous because if you have pneumonia, you get fluid leaking into the alveoli, and again, it's going to compromise that function of the respiratory membrane. If you have fluid in there or collapse of those alveoli, as we described before, it's not going to be easy for gas to diffuse across that membrane. Okay, so that's really important. And pneumonia can be very serious, right? And especially in young children or older individuals, it can be very dangerous. All right, so that wraps up sort of looking at how these things are structured in terms of the alveoli. What drives the movement of these gases is pressure. And you guys know that blood pressure in the pulmonary circuit is pretty low. Pulmonary vessels can be easily blocked by clots or fat or air bubbles, and that could result in what's called a pulmonary embolism, which would be a rupture, a very dangerous location in that process. All right, so what we want to look at next now is gas exchange. Okay, and as I've described this really already briefly, but we want to look closely at this process of respiration. And respiration, which is basically the whole process of getting gas and exchanging oxygen and CO2, has two integrated components. It has what's called external respiration and internal respiration. External respiration are basically all processes involved with exchanging oxygen and CO2 with the environment, whereas internal respiration is just the process of cellular respiration, where oxygen is actually consumed by the target cell and CO2 is given off within those individual cells. So for instance, external respiration is essentially breathing, of course, getting that oxygen down to the alveoli, crossing over the exchange surface, and then attaching to the red blood cell and traveling through the system. Once that oxygen that's attached to the red blood cells arrives at a target, like, say, for instance, the brain or the heart or the skeletal muscle, for instance, internal respiration is when that cell takes that oxygen in, right, and produces CO2, like when the skeletal muscle produces ATP, for instance, and utilizes that oxygen and produces CO2. That is internal respiration. Okay, so there are two separate processes involved here. Okay, and so again, basically, external respiration is all those processes involved in getting oxygen down to the blood, essentially. But internal is where that oxygen is given off to those tissues. All right. All right. So as I said, external respiration is the first big part of this, and can be broken down into three important components. Okay, so this is important to know. The three processes of external respiration are breathing, as I mentioned, of course, which we also refer to as pulmonary ventilation. We need the diffusion of that gas once it arrives to the alveoli across the membrane and capillary, and then again the actual transport of that oxygen and CO2 between the alveolar capillaries to the target. So that's a lot, right? I mean, most all these processes of external respiration do everything except actually exchange it at the target. So we need pulmonary ventilation, gas diffusion, and transport of the oxygen and the CO2. Okay, and so we want to look at all those processes to have a nice understanding of how this actually works. Okay, so pulmonary ventilation. Pulmonary ventilation is the actual physical movement of air in and out of the respiratory tract. And this will ultimately provide what's called alveolar ventilation, which is movement of the air in and out of the alveoli, right? And this is really driven, pulmonary ventilation is really driven by pressure, specifically atmospheric pressure, right? We have a certain amount of pressure in the atmosphere, and that weight moves air in and out of the respiratory tract. So that's a really important thing to understand, is how pressure works. And so we want to start looking at these gas pressures and volumes so we can understand exactly how this process works. And so there are a couple of laws that we have to understand this concept of pressure and atmospheric pressure and how gases move across the respiratory membrane. So the first thing we need to understand is Boyle's law. Okay? And Boyle's law is basically defining the relationship between a pressure of a given gas, and there are a lot of different types of gases, right? It's not only just oxygen that we'll be talking about, and that pressure with as it relates to volume. And so basically the relationship of Boyle's law is saying that if you decrease the volume of a given container where a gas is located, you're going to see an increase in pressure, and vice versa. If you increase the container volume where a gas is contained, you will see a decrease in pressure. And you can see that in this image, right? So think about, if you have a certain gas in a contained space, right? If I make this container where that gas is located smaller, right, the molecules within that container, right, the collisions are going to occur more frequently, and that's going to elevate the pressure inside this container, right? Okay, so there's a relationship between how much space is in that container and the pressure that's found in that container, okay? But if you increase the volume, right, that's, again, same amount of gas, can you see how there would be less pressure, right? Because there's going to be less collisions that are occurring, and so the pressure inside the container declines. So there's a direct relationship. Again, if you have a set amount of gas, if you change the amount of gas, obviously that's going to change things. But if you're looking at a set amount of gas and a set container size, smaller container will increase pressure, a larger container will decrease pressure. Okay? And so this is important to understand, because the container that we're going to be talking about is our thoracic cavity and our lungs, right? And that's going to change depending on what size the container is, what size is going on the space of our thoracic cavity is. Okay? So pressure and airflow to the lungs, air is going to flow from an area of higher pressure, right, to an area of lower pressure. It's kind of like a concentration gradient that we talked about, like with the movement of ions, right? And so breathing or respiration, the respiratory cycle, consists of inspiration and expiration, right? Inhalation and exhalation. And when you do that, when you inhale or exhale, you're changing the size of your cavity, your thoracic cavity essentially, and therefore altering the pressure, allowing for gas to move, right? And so pulmonary ventilation causes volume changes that create changes in pressure, right? The volume of the thoracic cavity is changing when you breathe in or exhale, right? Every time you do it. Just think about it. Take a deep breath in, and you can feel your cavity expand. Blow the air out, the cavity is going to decrease, right? And so if you're changing the size of the cavity, as we just described in Boyle's law, you're therefore going to be changing the pressure that's inside that cavity. Okay, so it's really important to understand Boyle's law as it relates to the changing of the size of our thoracic cavity, right? And so when the rib cage is elevated and the diaphragm contracts, for instance, right, the volume of the thoracic cavity is going to increase. So you're going to be opening the thoracic cavity more when you inhale, right? And again, just do that. You take a deep breath in, you can feel that cavity open because the diaphragm is pulling down, the ribs and sternum are elevating, and you're creating more space in that cavity, therefore less pressure in that cavity, right? And so if you think about three scenarios, you have rest, you have inspiration, and you have expiration. There's going to be a different pressure that's going on depending on that scenario. So at rest, okay, when you're not, which is only for a very brief moment in time, but when you're not either inhaling or exhaling, basically the pressure outside in the atmosphere and the pressure inside your thoracic cavity is pretty much equal, right? Pretty much the same, right? The pressure outside and inside are equal, so air movement does not occur. That's why you have to breathe to get the air flowing. So if you're not breathing, air is not going to flow because you're not changing the size of the cavity, right? So at rest, when you're not either inhaling or exhaling, the pressure outside the in the atmosphere and the pressure inside your lungs is pretty much the same. Okay, and so that's why you breathe, to get things flowing and get things moving. So when you inhale, at inhalation, right, you're going to, as I said, you're going to elevate the rib cage, contract the diaphragm, which is going to pull down, and you're going to increase the size of the thoracic cavity. Right? And so if you increase the size of this cavity right here, right, can you see how the pressure in that cavity is going to decrease? Now we talked about Boyle's law. If you increase that cavity size, you're going to decrease the pressure. And so as a result, air then flows into the lungs because you've changed the size of that cavity, therefore you've changed the pressure. You have decreased pressure now in the lungs, and so air is going to then flow into the lungs. Okay? So that's an important concept to understand. This is why air flows into our lungs when we inhale, right? We increase the size of the cavity of that thoracic cavity, and pressure decreases, and therefore air flows into the lungs. So that's when you breathe in. Then you exhale, of course. During exhalation, right, the rib cage returns back to its original position, the diaphragm relaxes, and the volume of the thoracic cavity then decreases, right? And so everything is decreasing, and as the thoracic cavity size decreases, then of course pressure is going up, right? Pressure now is higher inside as compared to the outside, and so air moves out of the lungs, as you can see in this illustration. So this is a really nice illustration showing what's happening, at that moment in time at rest when it's pretty much equal versus inspiration and then expiration. So make sure you have a really good understanding of why the air is flowing due to Boyle's law, right? Because as the volume is changing, the pressure is changing, and that's what's causing airflow. All right, so compliance then is how easily the lungs expand. Okay, low compliance requires greater force to work. Higher compliance requires less force, and there are things that can affect compliance, like the connective tissue structure of the lungs, the amount of surfactant, the mobility of the thoracic cage. All these things are going to impact how easily the lungs can expand. And muscles, a lot of muscles of our thorax drive this process. So for instance, if you ever had a situation where you pulled a muscle like in your back or your ribs or something like that, sometimes just breathing in can be very painful, right? And so that's an example of compliance being reduced, right? Making it harder to get air into your system, right? So compliance is really important, and again, compliance is driven a lot by muscles of respiration. The most important ones that we're going to talk about are the diaphragm, obviously, which is that smooth muscle that sits at the very bottom of the thoracic cavity, external and internal intercostal muscles, and some accessory muscles are really important in terms of respiration. So we'll look then at the actual physical mechanics of breathing and how these processes change to change the diameter of these, or the volume inside these cavities, to allow for airflow to move. So we have what's called inhalation and exhalation, of course. Inhalation is always an active process, meaning it's involving muscles actively that are working. Okay. Exhalation can actually be active or passive, depending really on the intensity of your breathing, right? So if you're just very relaxed, like probably sitting here right now, unless maybe you're listening to this while you're exercising or something, right? Your breathing is probably pretty passive, meaning that the connective tissues and the elastic components of our muscles and our bones and rib cage and everything, bringing everything back, can be a passive process. But inhalation is always an active process. Okay? And so we want to look at the muscles used in inhalation and exhalation so you can sort of see how this works. All right, so the muscles used in inhalation, the diaphragm, of course, this is actually 75% of normal air movement, right? The diaphragm contracts, pulls down, and opens that cavity that draws air into the lungs. So big player in breathing, obviously, is the diaphragm, 75% of that. There also are external intercostal muscles that also assist with inhalation. That makes up about 25% of normal air movement. And then there are some accessory muscles that also assist, like the sternocleidomastoid, the serratus, pectoralis minor, scalenes. These are all involved in accessory muscles of inhalation, right? And so again, the diaphragm and these other muscles essentially are working to expand that cavity, right, and get air into that cavity, right? And so here's a nice image of all the muscles of inhalation that I was talking about. Of course, the diaphragm is the primary muscle of inhalation. We also have the external intercostal muscles, right? Those are making up the primary, almost 100%. But then you have these accessory muscles like the sternocleidomastoid, which you guys learned back in A&P1, the serratus anterior, you guys learned that back in A&P1. Those are all muscles of inhalation, right? And you can see what happens, right? With inhalation, you have the intercostals and the diaphragm working to expand that cavity, right? And then the accessory ones are only active when needed. So like your sternocleidomastoid, the scalenes, and serratus, those are probably more used, when you have a, greater need for oxygen, like if you're exercising or you're having an asthma attack, you might be using more muscles to try to help expand that, open that cavity up more to get more air flowing deep into your lungs. Okay. Now, what about exhalation? Okay. Exhalation, you have muscles like the internal intercostals and the thoracic muscles that depress the ribs. Abdominal muscles can help force that diaphragm back into position and can be used during exhalation. Right. And so you can see these muscles listed during exhalation. Okay. As I said before, exhalation can be active or passive, and so we want to look at modes of breathing that dictate what's happening, right? And so respiratory movements are classified by what muscle activity is occurring. And basically you have quiet or forced breathing. Quiet breathing involves active inhalation, of course, but passive exhalation. And so that's probably, again, when you're just sort of relaxed, you can have diaphragmatic or deep breathing that's more dominated by the diaphragm, or coastal breathing, shallow breathing that can be dominated by rib cage movement. But again, quiet breathing is when you have more of a passive exhalation. You're not really breathing very heavily, for instance. Okay? Elastic rebound is essentially what derives this, as I talked about before, when those inhalation muscles relax, the elastic components of the muscles in the lungs recoil, and you get back into position. So that's what's driving that passive inhalation. Okay. Forced breathing, hyperpnea, involves both active inhalation and active exhalation. Right? It needs muscles, and this occurs again during exercise. Whenever you exercise, you're doing forced breathing because you're really trying. Your body has a high demand for oxygen. All those muscles that are working so hard, producing lots of ATP, they need lots of oxygen to work and to continue to make ATP. So that increases your heart rate, increases your respiration, and you get more oxygen down to those muscles, right? So that's what happens during exercise, but also can occur abnormally. I was describing conditions of low oxygen, like if you go to Colorado and you go for a big hike, that would be one thing. Just actually not even if you went for a hike in Colorado, just there's less oxygen at those higher elevations. But again, also like an asthma attack, other types of things could result in forced breathing. Okay. All right. So another topic we want to talk about as it associates with this breathing are respiratory rates and volumes, right? It's kind of like heart rate and stroke volume. Remember we talked about heart rate and stroke volume, right? How many beats a minute versus how much is being pumped out. Similar thing, right? Respiratory system is going to have to adapt to changing oxygen demand. As I said, your body, if you're exercising, right, your muscles have a much higher demand for oxygen so they can produce ATP. So you need to respond to that by either increasing the number of breaths with each minute, right, which is respiration rate, but also increase the volume of air that's moved with each breath, and that is tidal volume. So those two factors, again, it's kind of like heart rate and stroke volume equal cardiac output, right? The total amount that's going to be pushed out by the heart. Same thing with breathing. Respiratory rate and tidal volume are your two things you can work with to adjust how much oxygen is being delivered down to the alveoli. Okay? So you can calculate this, what's called respiratory minute volume, or V sub E, okay, which is the amount of air basically moved in a minute. And so you calculate by taking the respirations that are occurring each minute and multiply that by how much air is being pushed, right? So respiratory rate times tidal volume is going to give you V sub E. And a typical V sub E is typically about 12 breaths a minute, right? And the tidal volume is about 500 mL. So that's the volume, that's how many times. You multiply them together, you get about 6,000 mL, or 6 liters a minute is typically sort of an average V sub E, right? And that's kind of like, V sub E again is kind of like cardiac output. Heart rate times stroke volume is giving you cardiac output. Here, how many breaths a minute, which is kind of like heart rate, is multiplied by the tidal volume, which is kind of like stroke volume, and that gives you cardiac output. So it's a similar equation if that helps you understand what we're talking about here with V sub E, or respiratory minute volume. Now, there's another thing that you have to, an equation that you can do to figure out the efficiency of the system, and that is what's called alveolar ventilation, or V sub A. And V sub A is the amount of air or ventilation that's occurring all the way down to the alveoli. Okay, and so if you think about V sub E and respiratory minute volume, not all of that air that occurs in that minute is going to make it all the way down to those alveolar exchange surfaces, right? Because you have the lung, and you have the branching, and you have the trachea, and you have your mouth, right? Not all of that is going to make it down. And so we call that area where it doesn't actually get all the way down to the alveoli, we call that anatomic dead space. So for instance, of 500 mL of volume of air that you breathe in, right, about 150 mL is going to remain in those conducting passages, right? It's kind of like when the ventricles contract, right? We had end systolic volume and diastolic volume, right? You're not going to get every single last drop of blood out of the heart. There's going to be some left over. And that's kind of what happens with alveolar ventilation, or V sub A. Alveolar ventilation is the amount of air that actually reaches the alveoli each minute. And so you do the same thing, except you need to subtract out that anatomic dead space. So you're still taking tidal volume and respiratory rate, the things we talked about with V sub E, but you need to factor in the anatomic dead space, because not all of that air is going to make it down to the alveoli, right? So if you take a V sub A equation, using our previous examples, still 500 mL and still a 12 respiratory rate, right? But you need to subtract out the dead space. Truly, alveolar ventilation in this case would be 4.2 liters instead of 6 liters, right? So it's a fairly big difference. So make sure you understand V sub E and V sub A and how you can calculate what the difference is between those. All right? All right, so anyway, so these relationships between V sub E and V sub A are determined by respiratory rate and tidal volume, right? Those are the ways you can change it. For a given respiratory rate, you need to increase tidal volume to adjust alveolar ventilation, right? For a given tidal volume, then, if you can only push so much air, you need to increase the respiratory rate. So depending on the scenario, right, your body may try to adapt by either pushing more air or just breathing at a higher respiratory rate to adjust and increase V sub A. All right? And there are pulmonary function tests. Spirometry is something we do. We're going to start doing in lab, where you guys can actually see that measures how much air is being moved and the rates and the volume of air movements. And so spirometry allows, set standards of what, an individual should be able, how much air an individual should be able to move. And if you don't reach those standards, then that helps you diagnose the problem with ventilation. All right? All right, so this just shows, total lung capacity between males and females, so you can give you an idea of that if you like. All right, so that was the first part of this process, right? So if you went back to the beginning, we said Pulmonary ventilation is the first process of external respiration. Then we said you have to have the actual gas exchange, right? So once that air, which is the first part we just described, gets all the way down to the alveoli, then gas exchange has to occur. So that's the next really important component of this, right? And so gas exchange occurs between the blood and the alveolar air across this respiratory membrane, as I mentioned, right? And so this depends on the partial pressure of the gases, right? And the diffusion of these molecules between a gas and a liquid. Okay? And so we need to understand, like we did with Boyle's law, we need to understand some gas laws to see why diffusion occurs. Okay? And so rates of diffusion depends on certain physical principles or gas laws. And so the first thing we understand is Dalton's law of partial pressures. This states that the air we breathe is essentially a mixture of gases, right? Nitrogen, oxygen, water, CO2, right? The vast component of that is nitrogen that's in our atmosphere, the air we breathe. But about 20% of that is oxygen, okay? And so based on that, right, atmospheric pressure is about 760 millimeters of mercury. That is produced by all these different air molecules from these different components bumping into one another. And so each gas, then, like nitrogen and oxygen and other components, contribute to that total pressure, right, in its proportion to its number of molecules. That's Dalton's law, okay? And so partial pressure is the pressure contributed by each gas, right? So if you have the pressure of nitrogen, oxygen, water, CO2, all those components added up is going to give you 760, right? So therefore, the partial pressure of oxygen then, right, is, we said it was 20.9%. So you just take 20.9% of that 760, gives you 159. So 159, the pressure of oxygen is about 159 of that total pressure of our atmosphere, which is 760. And so you get partial pressures of those, okay? And so understanding that is going to help you understand Henry's law, which states that when gas under pressure comes in contact with the liquid, the gas will dissolve until an equilibrium is reached. And so a soda can is a great example of Henry's law, right? If you have a certain amount of gas, like carbon dioxide in a solution inside the container, it's going to be fine, right? The gas is going to stay and it's going to remain in that, for the most part, for a long period of time, okay? But once you open that container, right, and you change the pressure now, and the gas pressure is going to decrease, of course, because you have a much bigger space, for instance, right? The dissolved gas molecules will leave the solution until there's more of an equilibrium with the atmosphere, right? And so the atmospheric equilibrium of CO2 obviously is much different. So that's why soda then becomes flat, right? Because all those CO2 that was once contained inside that small soda can will diffuse out into the atmosphere to try to create an equilibrium, okay? So Henry's law, at a given temperature, the amount of gas is proportional to those partial pressures of that gas and its solubility. So for instance, solubility varies in body fluids. So CO2, for instance, is very soluble, and we'll see that's how your body actually processes some CO2 in the blood. It can go through solubility in the blood, actually. Oxygen is less soluble, which is why it has to be bound to red blood cells to be carried, right? And so we'll look at mostly we'll look at CO2 and oxygen in terms of how they're carried and how they're transported in this gas exchange, okay? So diffusion of these materials, direct diffusion gases across this membrane determine the partial pressures and solubility that's occurring, okay? And so there are 5 reasons that gas exchange is very efficient, right? First of all is the difference of the partial pressure across that membrane. It's kind of like when we talked about the movement of ions, like at the nervous system, for instance, right? When you have a depolarization occurring, you have all these sodium ions outside and they're prevented from entering. But if you open those pathways, what's going to happen to those sodium ions? They're going to rush into the cell, right? Because there's a big difference across that membrane. Same thing happens here, right? If you have a lot of oxygen gas outside and it arrives at a location, it's going to move into the cell. Okay? So that difference in partial pressure across that membrane is then going to drive the movement of those gases across that membrane. Okay? So that's one big factor. Another one is the distances involved in the gas exchange are very short. As we said, oxygen and CO2 are lipid soluble, which allows them to cross that membrane, which is also a lipid-based membrane. The total surface area is very large. You get a lot of efficiency of gas exchange, and blood flow and airflow are very, very coordinated in that process. Okay? So, for instance, partial pressures in alveolar air and the alveolar capillaries is going to be different, right? Blood arriving at the pulmonary artery has a lower partial pressure of oxygen and a higher pressure of CO2, and that concentration gradient then causes oxygen to enter the blood and CO2 to leave the blood. So this rapid exchange allows for equilibrium to occur. Okay? And so oxygenated blood mixes with deoxygenated blood, and that pressure will then alter. Right? And so in interstitial fluids, the concentration gradient in these peripheral capillaries is essentially opposite of what you see in the lungs. So the CO2 diffuses into the blood, and the oxygen diffuses out of the blood. Right? And that's basically the process of movement of oxygen. Right? So, for instance, here is the alveolus, here is your blood flow, right? And so you have deoxygenated blood coming to the alveoli, right? Coming from the heart, as we talked about, after deoxygenated blood, and this is the location right here, right? You guys know the right ventricle pumps blood to the lungs to reacquire oxygen. It goes this way and it goes this way, right? And so this is the area that we're looking at in this image right here. Okay, and so here is the deoxygenated blood arriving. Look at the partial pressure of oxygen as it arrives from the right ventricle, which you guys know is deoxygenated blood, right? It's only about 40, the partial pressure. But look at the partial pressure of oxygen in the alveoli. Look at that, 100, right? Big difference. So what does that mean? Well, the oxygen then is going to move, right? Because we said the pressure gradient causes, you want to try to get more of an equilibrium. So then the oxygen goes into the bloodstream, and now look at the partial pressure of oxygen is now to 100. Okay, and so that gives you an idea of why oxygen moves. Same thing with CO2, right? Higher CO2 in the blood at this time, deoxygenated blood, lower in the alveoli, so the CO2 moves this way, right? Okay, so that's external respiration. Okay, internal respiration, same thing. When that blood now that has a higher pressure and our oxygenated blood arrives at the target, of course the oxygen is going to move into the tissues, CO2 will move out, again driven by these partial pressures. Okay, so make sure you have a good understanding of those partial pressures and sort of how that works. Now, as we said, gas transport occurs, pickup and delivery by the red blood cells. As you guys know, red blood cells have the ability to bind and transport oxygen and CO2, right? They can also remove oxygen and CO2 from the plasma, and that's what allows this exchange to occur. Okay, so oxygen transport. Oxygen binds to the hemoglobin, as you guys know. It's a very reversible reaction where oxygen can be easily given off to that tissue. Okay, and so hemoglobin saturation then is the percentage of that iron, that heme, that is bound to oxygen. And so that hemoglobin saturation shows that your red blood cells are working properly in terms of carrying a lot of that oxygen. And so carbon monoxide, right, which is the CO from burning fuels, binds very strongly to hemoglobin and takes up all those spaces where the oxygen is supposed to be, and that's why being in a enclosed space with lots of carbon monoxide or a lot of CO can lead to carbon monoxide poisoning, right, because it takes all of the space for where the oxygen is supposed to go. All right? All right, so CO2 transport's a little bit different. Again, a lot of it is bound to red blood cells, about 23%. About 70% of CO2 in the bloodstream is converted to what's called carbonic acid. And again, since CO2 has a higher solubility, we're seeing about 7% of it actually dissolved in plasma. So it's a little bit different pathway for this CO2. And as you guys know, CO2 is generated as a byproduct of aerobic metabolism or cellular respiration. And so the CO2 needs to be expelled as well. And those are the three ways the CO2 is expelled. All right? And so this shows, again, CO2, right, as a result of aerobic metabolism, right? We see CO2 diffusing into the bloodstream. 93% of it is diffusing into the red blood cell. 23 is binding to the hemoglobin. 70 is converted to what's carbonic acid, essentially. But 7% can just dissolve in the plasma. So make sure you have a good understanding of how CO2, is carried in the body, okay? Or in the blood, I should say. And this is a nice shot showing really the whole flow, the whole process of gas transport, right? You have oxygen being delivered to the alveoli, and it's going into the blood, right? Being bound to the red blood cell. That's then traveling through the systemic system where you have oxygenated blood. It's going to arrive at the target, which is cells like muscle cells, brain cells, heart cells, right? And the oxygen is given off to the target, right? At the same time, the amount of CO2 that's being produced from aerobic metabolism is driven back into the cell. Red blood cell has many different ways of carrying the CO2 that returns back to the alveoli where it's given back off and you exhale out the CO2. So that's a nice sort of overall view of oxygen pickup, oxygen delivery, CO2 pickup, and CO2 delivery. All right, so make sure you have a good understanding of how that works. There are some effects of aging on the respiratory system. Over time, elastic tissues deteriorate, and so lung compliance and vital capacity can be impacted. Arthritic changes, right? Our chest can't expand as much, so that's obviously going to limit respiratory minute volume. And then emphysema, of course, which can happen in individuals over 50, depending on exposure to like smoke and other types of things, can lead to emphysema. And so this just chart sort of shows, again, even normal healthy lungs, someone who's never smoked, you're going to see a decline in respiratory function. But look at how severe it is in someone who smokes. But people who stop smoking, which is why it's motivating for people to stop smoking, you can gain some of that respiratory function back. Okay? But even normal, healthy lungs are going to see some decline, really even by the age of 50, and then again at the age of 75, even much later. All right? All right, so that wraps up this lecture, and that'll be it for this unit. We're doing lymphatics and respiration, so this will be the exam will be on these two chapters for exam number 2. All right?